Welcome to Oncology Morning Commute, Follicular Lymphoma. Haven't we met before? Morning Commute is developed by Projects and Knowledge, powered by Kaplan, and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Bayer Healthcare Pharmaceuticals Incorporated and Novartis Pharmaceuticals Corporation. In this podcast series, our faculty will discuss follicular lymphoma, its management, first, second, and third-line treatments, including some of the newer therapies, for example, the PI3 kinase inhibitors, copanlisib and duvelisib, and the CAR T-cell inhibitors, including axi-cel, lisa-cel, and tisa-cel, as well as bispecific antibodies such as mosunetuzumab. In this episode, Dr. Christopher Flowers and Dr. Loretta Dostapil take a look at third-line treatment options for follicular lymphoma patients. Information about the faculty and disclosures can be found at morningcommutepodcast.com/FL3. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Flowers is a professor and ad interim division head in the Division of Cancer Medicine in the Department of Lymphoma Myeloma at the University of Texas MD Anderson Cancer Center in Houston. Dr. Dostapil is an associate professor also in the Department of Lymphoma Myeloma at the University of Texas MD Anderson Cancer Center in Houston. I am your host, Candace Hoffman. Dr. Flowers will begin our discussion.
Thanks, Dr. Dostapil, for joining me again for this third episode on our series on follicular lymphoma. We spent time talking about patients in the frontline therapy for the first podcast, and then talked a little bit about early progression of disease and second-line therapy. Let's now turn to the third-line treatment options for patients with follicular lymphoma. And maybe start this off with the kind of typical patient with follicular lymphoma who presents with relatively low tumor burden disease, has initial therapy with single-agent rituximab that produces a remission for a few years of therapy, but then ultimately has relapse with a more high tumor burden disease, is treated with bendamustine and rituximab without any sort of maintenance therapy following that. But now, after that line of therapy, a few years later, it now has returned to the follicular lymphoma. What kinds of conversations do you have with that kind of patient, and how do you think through what to do next?
I think you raised some really important points to consider. Each patient at a given line of therapy is going to come into this scenario with some history, and that history is, well, what were their prior lines of treatment? How intensive was that therapy? What was the toxicity of that treatment? And what was the remission duration following those lines of therapy? What do they look like at the time you're making a treatment decision? Meaning, what comorbidities do they have? How is their functional status? What is their objective or goal for the outcome of that next line of treatment? And so it's pretty complex when you think about it. And so I'm glad you framed it with giving me information on what their prior line of treatment was to help me formulate that discussion. I do take into account what their last treatment was, how long that remission was. So this is a patient who had single-agent rituximab, bendamustine rituximab, and now they're approaching third line. And the assumption is that they need active treatment. Fortunately for patients, there's a longer list of options in that third line or later space as a result of several single-arm phase 2 studies, even some randomized trials that may help inform that decision. My general preference, or how I formulate that discussion, is I will walk them through the targeted approaches. If there's no signs of transformed disease, or I don't have any concern about underlying aggressive behaving disease, I'm usually going to stick with a targeted approach, because my general assumption is that the toxicity profile may be a little bit more favorable than pursuing an anthracycline-based regimen. And my options there are lenalidomide and rituximab. We've got copanlisib, either a single agent or maybe even with rituximab, based off of a recent randomized study. You have novel therapies that are available on trial. And then we've got tazemetostat, which is an EZH2 inhibitor. So one thing that might be helpful and is new is understanding whether or not they have an EZH2 mutation. Now, we could spend a lot of time talking about that, and I want your opinion. at least based off of the single-arm phase 2 study, response rates were higher with single-agent tazemetostat among those patients who had an EZH2 mutation, which is only about maybe 10 to 30% of patients with follicular lymphoma. Though the median progression-free survival was only different by about 2 months, 11 months among those that were wild type versus almost 14 months for those that had the mutation. So you could look at that and say, well, it doesn't really matter what their mutation status is, but that is one way that I might stratify across the various treatment options. Do they have a mutation status? Are they going to tolerate toxicity? We mentioned in our prior podcast that lenalidomide rituximab has similar toxicities to chemoimmunotherapy with cytopenias, fatigue, maybe risk of infection are worth considering. And then the PI3 kinase inhibitors, which we'll spend, I'm sure, more time talking about in the later section, the toxicity associated with those agents. So I might prefer lenalidomide rituximab first, just because it's time-limited therapy, but I will walk through the other options as I outlined.
I think those are exactly the same kinds of approaches that I would think through with a patient in exactly that same situation. Maybe addressing first the point that you raised about EZH2 inhibitors. I think one of the challenges that we've faced in follicular lymphoma, really again, lymphomas overall, is the use of mutation status and molecular testing in our diseases to make decisions about therapy. Now that we have the EZH2 inhibitor tazemetostat as a therapy where mutation status helps us to define the patient population that may respond better. Hopefully mutation status will move more to the forefront in our lymphoma therapies. But up to this point, there have been relatively few patients that we've even had that information on to be able to make those decisions. And so I'm hopeful that we'll see more mutation status testing. And as we get more mutation status testing, we'll hopefully have even more drugs to be able to act upon that. I mean, with the specific data that you mentioned about the EZH2 inhibitor tazemetostat, we know that those patients who are EZH2 mutants have a better response rate to therapy, so about a 69% response rate to therapy as opposed to 35% response rate for those who have EZH2 wild type disease. But as you mentioned, the progression-free survival appears to be relatively similar for those two agents. And so, from one standpoint, the mutation status helps you with knowing the response rate, but may not change quite so much about how well those responses are durable. That being said, as you mentioned, the EZH2, the rough number that I use is about 20% of patients with follicular lymphoma are EZH2 mutant, so that there will be more responses overall in those 80% of patients who are EZH2 wild type than the 20% who are mutants, even though the response rate is much higher than that population. And so I think at this point, the mutation status helps us to some degree, but not perfectly. I guess another population to think about, we talked about this patient who had rituximab in the first line setting, and then bendamustine rituximab in the second line as somebody who's had long durable responses with relatively slowly progressing disease. How do you think through the role of lenalidomide and rituximab versus R-CHOP in the third line setting for a patient with follicular lymphoma? And when do you think about more aggressive therapies for those types of patients?
Yeah, I generally am of the school of thought that I'm going to use an anthracycline when I'm worried about transform lymphoma. So oftentimes I'm going to pursue a biopsy just to make sure I know what I'm treating. But what if the biopsy is not feasible? Or what if it tells me something I wasn't expecting? And when would that be true? Generally, if I have patients that have significant B symptoms, their LDH is quite high, they may even have hypercalcemia. To me, that's transformed disease until proven otherwise. And that may be a scenario where I may favor an anthracycline-based approach. Obviously, if I have a biopsy that has any hints of transformed disease, I'm going to pursue that over a lenalidomide and rituximab option. What if I have a patient who's got cardiomyopathy, though, and an anthracycline is not a reasonable option? Then I might consider lenalidomide rituximab. I think the other big question to me is, when would I consider CAR T over those options in that third line space? And so we don't have a wealth of data to help us understand what's the proper sequencing of treatment. But at least in mantle cell lymphoma, what we have learned is for patients who had bendamustine treatment in their last line of therapy prior to Brexucell, for instance, if that had occurred within 6 months of that CAR T cell therapy, their outcomes were much less favorable. So again, not specific to this situation, but I do think it matters when they've had bendamustine-based approaches and how that impacts my next line of treatment. I think the toxicity profile matters when I have a wealth of options, but I'm also juggling that with efficacy. And without a lot of studies that are comparing across these mechanisms of action, I do think we're balancing, again, the desire to have improved PFS with the toxicity profile.
Podcast number 5, we'll spend a lot more time talking about toxicity and talk about the toxicity of the EZH2 inhibitors, the PI3 kinase inhibitors, CAR T cell therapy, as well as the R-squared regimen, and maybe even some of the newer emerging therapies. Spend most of the time today talking about the efficacy of these agents, and we've talked about chemoimmunotherapy, and specifically about R-CHOP, and talked a little bit about the regimens that we use. What about some of the older chemoimmunotherapy regimens that we've used to use? And are there any of those that you would ever think about for a patient with follicular lymphoma, like fludarabine-based regimens or CVP, which was more commonly used in the frontline setting, or the kinds of regimens that we would use for aggressive lymphomas, like RICE or RDHAP? When, if ever, do you think about using those kinds of treatments for a patient with follicular lymphoma?
A really good question. I would say fludarabine has not been used in the last few years in my practice outside of lymphodepletion prior to CAR T. Not that it's not an effective strategy, it's clearly effective. I think the challenges with fludarabine have been the toxicity, specifically infection, and the prolonged lymphopenia. I think you could make a similar argument with bendamustine. That's probably why some folks are still utilizing things like our CVP with the expectation that you're going to get cytoreduction, but you're not going to have as long of an impact on T cell subsets. So that's, I think, perfectly reasonable to consider. I think I've always been slightly disappointed at the efficacy associated with RCVP when we've looked at any sort of comparison to other chemotherapy-based options, but the toxicity profile is reasonable. For the more intensive sort of platinum-based salvage approaches, I've not routinely done that outside of a scenario where, again, I think that there's underlying transformed disease in a patient that may have had a prior anthracycline in terms of frontline. I don't have a preference among the available platinum-based options. I think most people use RICE more often than others, just based off of the toxicity profile and sort of ease of use. Least some hint that there might be some distinction in efficacy based off of cell of origin when we look at subgroup analysis of the CORAL study. Again, this is large cell specific, but because many of these patients have a germinal center derived lymphoma, maybe that might impact me in terms of choosing something that's more cytarabine based platinum approach. But again, not something that I'm doing on a regular basis.
So we've talked through chemoimmunotherapy-based approaches and through the use of EZH2 inhibitors in the third-line therapy. What about PI3 kinase inhibitors? And so as you know, a few of the agents have been withdrawn from the market now, idelalisib, umbralisib, and duvelisib, but copanlisib remains as a therapy that's available to patients. When do you think about a PI3 kinase inhibitor, and what are the responses that we see associated with that agent?
In my practice, I generally am reserving a PI3 kinase inhibitor after patients have failed chemoimmunotherapy and a lenalidomide in combination with CD20 approach. And again, it's mostly just based off of duration of therapy. When we initiate treatment with the PI3 kinase inhibitors, we're generally treating until progression or intolerance. As you've mentioned, several of them have been removed from the market. Some of that is actually due to concerns about toxicity and later randomized studies, but some of it was also just low enthusiasm in terms of completing some of those trials. I think the community at large does not have as much enthusiasm surrounding PI3 kinase inhibitors as other mechanisms of action, whether or not it's the toxicity profile, the lengthy duration of therapy. So it's probably a combination of both of those factors. Where I utilize something like copanlisib is usually in that third line or later space for patients who have not or progressing beyond lenalidomide. And potentially I'm going to use it to sort of bridge them in a sense to their next treatment, which may be CAR T, and particularly for patients who don't have good oral options. I think the challenges with copanlisib we'll talk about is the fact that you have to be careful in patients that don't have controlled type 2 diabetes or don't have controlled hypertension, but the intermittent IV dosing does meet an unmet need, particularly for those patients who don't have good oral coverage.
I completely agree with you on those points. As someone who was involved in the trials on the early oral PI3 kinase inhibitors, these are agents that have good response rates in patients with follicular lymphoma, response rates in the 40 to 50% range, and have in general a progression-free survival of about a year. But because of the toxicities and the areas that you mentioned, a number of them have been withdrawn from the market. Perhaps copanlisib has ways of being able to address some of those because it's given IV, and so because it's given intermittently, and many of those toxicities, at least with the oral agents, have been more associated with continuous dosing that may help to address some of those. The flip side is that because it's IV, it makes it a little bit more challenging for administration to patients who would prefer to have that oral dosing of an agent that they could manage on an outpatient basis, particularly when there are now oral alternatives like the EZH2 inhibitors and lenalidomide in this space. Maybe turning to another component at an area where you've been very involved, and that's the development of CAR T-cell therapy for patients with lymphoma. How do you think about the use of CAR T-cell in follicular lymphoma? Who are the patients that you consider for CAR T-cell therapy, and what do we see in terms of responses there?
So my first impression of the data, at least from ZUMA-5, which was a single-arm phase 2 study looking at Axi-cell, which is a CD19, CD28 autologous CAR, we haven't seen PFS in that third line or later space quite as striking. So the median PFS among the follicular lymphoma patients in that study was 39 months. When we look at the ALARA study, which again is an auto CD19 4-1BB construct that has differences in the construct, but probably what's most striking about it is the toxicity profile looks to be very favorable. Again, very favorable outcomes. Now, what we can learn from these single-arm phase 2 studies is they were done in young patients that were progressing quite quickly through multiple lines of therapy. So that's exactly who I consider for CAR T. We mentioned the POD24 patients, but those patients that are progressing quickly through multiple lines of effective therapy, this is not, rituximab monotherapy, for instance, but patients who've had chemoimmunotherapy, they've had a second line that's lenalidomide based, and they're still progressing quickly. Those are the patients I'm going to consider CAR T for. The other patients where I think this can be very helpful is for those transformed follicular. We know across the large cell studies that those patients tend to do quite well with CAR T cell therapy. Where I'm struggling a little bit is what about for that 72-year-old patient who's not progressing rapidly through treatment, but also doesn't want to be on therapy for a prolonged period of time? Is the toxicity justifiable? So how would you handle that patient?
So I think that's an incredible question. I first agree with you about what you said about the effectiveness of CAR T-cell therapy in these patient populations. So we know from the National Lymphocare study and other observational studies that we talked about in our first podcast, that if you look at patients as they go through lines of therapy, those responses tend to be quite good for first-line therapy and reasonable for second-line therapy. But by third or later line of therapy, those are generally at 1 year or less in terms of the progression-free survival. And so to see progression-free survival of more than 3 years with a therapy, albeit in a relatively selected patient population, that's really quite impressive. And so I think what needs to hold is how widely these therapies can be used, and in particular for that 72-year-old patient that you mentioned, that those are the kinds of patients that we typically see in follicular lymphoma, particularly in those later lines of therapy. I think one of the things that my experience with taking care of patients with CAR T-cell therapy and experience with taking care of patients with follicular lymphoma has shown is that you can't use age by itself as a prognostic or predictive factor for the kinds of therapy that a patient can take. And so for that particular patient, I'd want to know a lot more about comorbidities in terms of what other kinds of toxicities that you might be concerned about with CAR T-cell therapy. I also would want to know about quality of life and goals of therapy. And as you mentioned, if this is the kind of person who really did not enjoy being on prolonged therapy with an oral agent that you take indefinitely or another kinds of therapy that you take for a long period of time and would prefer an approach using CAR T-cell that could use intermittent therapy, albeit with prolonged follow-up care, that those approaches are quite viable. You know, I will mention therapies that used to be used in follicular lymphoma are no longer used. The one that links quite closely to this is the use of radioimmunotherapy, where we used to give a single dose of a CD20-directed radioimmunotherapy that produced quite prolonged responses, and patients actually appreciated that as a therapy that could be utilized in the past. And I think CAR T-cells may fill that kind of niche for many patients who can tolerate it. Tell me about how you approach age and CAR T-cell therapy, particularly in this follicular lymphoma patient population. Is there an age at which you would consider that CAR T-cell therapy is not a viable option?
No, as you mentioned, I think functional status, comorbidities far outweigh just age in isolation. Though in my experience, as patients age, they tend to have worsening performance status. They tend to accumulate comorbidities that probably play a larger role than whenever we are dealing with young patients. So where it does factor into my decisions is if I have two CAR Ts that are otherwise considered to be equivalent in terms of efficacy, I'm going to choose the CAR T that's better tolerated for my patients that are older. So for instance, we have the T-cell option, which again is a Form BB construct. We haven't compared them head to head in terms of efficacy, but if the efficacy looks to be comparable, and in my opinion, it probably is, definitely going to choose a better tolerated CAR T for those patients that are older or frailer. So I agree with you. We never consider age alone, but there's oftentimes lots of factors associated with that older age.
Well, as I mentioned, we'll talk more about toxicity in a later lecture, but maybe in our last few minutes, we'll go rapid fire through a few cases of patients with follicular lymphoma in certain scenarios and get your take on how you would think about approaching those patients. So the first is a patient with follicular lymphoma who has evidence of transformation and got treated with R-CHOP therapy for that transformation, and then had maintenance therapy with rituximab following that. And then 5 years after that is now relapsed with follicular lymphoma, got single agent rituximab, and had another about 14-month remission, and now is relapsed again. What kinds of treatments do you think about in that scenario?
You get all the options we talked about today. So you still haven't exposed this patient to bendamustine. You've got lenalidomide in combination with rituximab. You've got the PI3 kinase inhibitors. You've got CAR T-cell therapy. You've got EZH2. Again, depending on performance status, comorbidities, whether or not the patient has any cytopenias, I probably will lean towards bendamustine in combination with rituximab versus lenalidomide rituximab and just walk through the differences in terms of the safety profile, the schedule, and make a treatment decision.
The second one is perhaps a newer scenario. So someone who had lenalidomide and rituximab as their upfront regimen, had that therapy and stopped after about 18 months of therapy because of progression of disease, and then went on to have bendamustine rituximab as the second line therapy at that progression. What do you think about in third line therapy for that patient?
This is someone who's had good therapy. And again, depending on how long the remission periods have been, I might actually consider CAR T-cell therapy for that next line of therapy. If it's an older, frailer person or the toxicity profile is just not very attractive, then in that setting, I might pursue copanlisib first with the expectation that my next line of treatment may be either a bispecific or CAR T.
Well, it's been a really great discussion. I might throw in the EZH2 inhibitor to that last as a last option for that particular patient. But I think any of the other options that you mentioned are also viable ones, and always clinical trials for a patient who's had, aggressive behaving disease of that kind. So stay tuned for our next podcast where we'll talk more about follicular lymphoma. This has been a fantastic discussion, and looking forward to talking to you in our next session.
Thank you.
Remember to receive your credit and evaluate this program. Please visit morningcommutepodcast.com/FL3. Look for all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.